Well, let me tell you, if you look at some of the large databases from the government, overall, in advanced cancer in the United States of America, the #1 country in the world, the percentage of patients in clinical trial remains less than 10%. It's getting better, but remains less than 10%. So there are several trials David and I and the group at Mass General we were involved in. One is COMPARS. It's a large study to compare sunitinib versus pazopanib, both FDA approved. So someone may tell me, I had a patient, I offered to him, said, so what's FDA approved? Just pick one. Well, it's very important to know if, for example, pazopanib, like it seems to be, but not sure, really is better tolerated than sunitinib. Record 3 is a trial that I personally did not, either David, I think, participated in, that compares sunitinib versus everolimus. Currently, everolimus is second option after you fail the first drug. So maybe if we start by this first, it's better. This is the rationale. Large trial include what we call the TiVo-1 trial, has no relationship to the TiVo-TV, with a drug called tivozanib, not tivozanib, versus Nexavar in the frontline trial. This trial accrued very, very well. We did not have it open, very few centers in the United States, a lot of centers were in Eastern Europe. And then there is this trial run by Tom Hodgson that finished accrual that compared Nexavar versus Toricel. There are also a series of vaccine trials in untreated patients with sunitinib. These are not the immunotherapy that David was talking about with the PD-1 or IL-2. These are some dendritic cell vaccine, because there is data there, lab data, and some from patients, that sunitinib synergizes well with immunotherapy. And there are also combination of targeted agents. Combination of target agents, like what? Well, this is on purpose a complicated slide. This is a paper I wrote with one of my colleagues, Kevin Courtney, to illustrate how complicated. And when a scientist look at this, a big scientist laughs because it's not complicated to him, and because there's at least 50 other more molecules to put here. This is the interaction between the tumor cells, so anything here, and the endothelial cell, and thinks that the blood is here, okay? And the receptor, where is VEGF? Where is the VEGF receptor? What the tumor cell has? Where is the mTOR? Toricel, temsirolimus, everolimus, Toricel, Afinitor are mTOR inhibitor. One of the realities people don't speak about, that mTOR comes in two flavors. mTOR C1, the complex one, and mTOR C2. And this drug only inhibit mTOR C1, and there's a feedback loop that goes and activate the rest. And this is a big possibility, and the reason why these drugs works initially perhaps, but then they stop working. So for example, going upstream and inhibiting AKT, and there was a trial with Dan Shaw, with our group at the Harvard Cancer Center, or with a PI3 kinase, which is an upstream that inhibit all this, is something reasonable. So we are going to launch a trial that combines Avastin plus a novel PI3 kinase inhibitor, a phase 1 plus expansion cohort. I did choose Avastin because it's the only drug so far that has proven to be okay to combine, and because VEGF remains very, very important in kidney cancer, and this trial will allow clear cell and papillary kidney cancer. There's another trial we have that combines Sutent plus Gemzar. Gemzar is an old chemotherapy, drug that is FDA approved or approved in pancreatic cancer, in lung cancer, in ovarian cancer, in lung cancer, etc. But in cytotoxic chemotherapy, I was just telling you, and Dr. Seller, does not work in kidney cancer. So why are we combining this? Well, in poor risk kidney cancer, maybe patient cells proliferate more, and especially in a very small subgroup we didn't mention, because it's not an entity itself, called sarcomatoid renal cell. And those patients that have small entity that behave like sarcoma and proliferate fast, normally, we give them Sutent or other drug in this, in one of the algorithms you've seen. But perhaps these are the ones that need a drug that targets the cell itself. So we have launched a phase 2 trial in those particular subset with Sutent and Gemzar. We have also going to launch this trial, Avastin and PI3 kinase inhibitor. And Dr. McDermott and myself, we're bringing some trial with this PD-1 inhibitor trial that is a novel immunotherapy that shows some encouraging activity and the toxicity profile. I think the hype around these agents is that this is not interleukin-2 related. This is something that is much less toxic. And there was some activity in a phase 1 study that led to 2 phase 2 studies that brought in. But be very, very careful. And that's one of the most vexing and frustrating things in my field, that people have to meet first the eligibility criteria. Second, if something is working for you, I had, someone, stuff working for them, stay on that. This is working. This is great. That's the biggest litmus test. And some people may not meet the eligibility criteria. For example, for the PD-1 inhibitor trial, if you look at the eligibility criteria, mostly people have to have a clear cell RCC. And how we and other and company and investigator decide on eligibility criteria, it's really not very easy here. So for example, I did want to include a lot of papillary, but in fact, the basic science data and everything is about clear cell. Nobody looked at papillary, so how can you justify putting it to papillary except just giving another option? Sometimes therapies are limited to up to 3 prior therapies here, but here any therapies as long as you did not receive Avastin or PI3 kinase inhibitor. But for example, with a PI3 kinase inhibitor, we know the blood sugar goes up. So if for some reason people overlook the fact that you have diabetes and it's not well controlled, you can be part of this trial. So it is really a process that initially is not easy, it's hard, because kidney cancer in general is a disease of people. The average age is between 60 and 65, although we have a lot of younger patients. So people 60, 65 tend to have sometimes some diabetes, some hypertension, history of heart attack. Those are very, very common. It doesn't mean that they do not meet eligibility, but it means that we have to look. What is also interesting, based on all these successes and now patients have options, is that investigators are now trying to look at the localized disease setting. So post-surgery adjuvant therapy in patients at risk for recurrent disease.